Hello, my name's Natalie Pattison. I'm a Professor of Nursing at the University of Hertfordshire. I also work at the Eastern North Herts NHS Trust, and today I'm going to talk to you about caring for critically ill people, both pre-pandemic and as a result of the pandemic. As of today, we know that there are a very large number of cases across Europe, and the UK has one of the highest numbers in Europe, over 429,000. We also know that sadly, over 41,000 people have died so far in the UK. And actually, we're the highest number of deaths across Europe in the UK. Now, usually, when people are admitted to critical care, because they are seriously ill and need supportive care in order to help them survive their serious illness, around 17 out of 100 people will sadly die. As a result of the COVID-19 pandemic, we know from global figures that around 41 people out of every 100 that are admitted to critical care will die. In the UK, it's ever so slightly lower at 39%, but we know this is still much increased compared to the usual figures that we see for critical care. As you can see from this image here, critical care involves an awful lot of equipment, and patients are the sickest patients in the hospital. Critical care is also sometimes known as intensive care, and here you can see the levels of treatment and equipment that many patients require. In COVID, we have seen that these patients are very sick, with significant respiratory deterioration, requiring ventilation. We also are used to nursing patients one-to-one, so you have one nurse to one critical care patient. However, during the pandemic, this has not been possible, and this has created great strain for nursing and for some of our medical staff who are also seeing increased ratios. We have had to expand critical care services and beds across the UK, and this is reflected globally as well. With my colleague, Professor Ruth Endicott, we have also examined the consequences of some of this and are taking this forward in the seismic study. "11,000 patients have been admitted to critical care units across the UK with COVID-19 since March 2020. And that's of 138,000 that have been admitted to hospital overall. We know that around 1% of people who contract COVID-19 will become critically ill, but what we don't know is why, and I'll come on to that later. I call my programme of work Critical Care Supportive Care, and this emulates the cancer supportive care model, where we support people with all of their needs throughout the trajectory of critical illness. So as you can see here, this is my programme of research and the trajectory of patients who go through critical care. They may survive, or sadly they may die, and my supportive care programme covers these different aspects. I also work clinically, so I'm a clinical professor of nursing, and I work 50% of my time in the NHS. I lead the critical care recovery service, and I also work within the research department in the trust. So we know that during acute deterioration, decision-making and supportive processes often don't go very well, with families and patients experiencing poor communication, suboptimal care, conflict, discomfort and distress. So one of our areas of research is to try and ensure that patients have a better experience. Family and person-centred care, and understanding how we can enhance the critical illness experience for patients and supporting patients. But also to make sure that we think about co-designing services that meet their needs. We want to help support the transitions of care, either towards discharge or, sadly on occasion, towards dying and end-of-life care, helping people receive the appropriate and best care that they can. We want to think about how we can ensure our critical care recovery and the follow-up models reflect the care that people actually need. So not just those who elect to maybe engage with services, but how we support everybody who's been discharged from critical care. We also want to think about the families of those who've been bereaved by people who've died in critical care and what support we can give them. And on the back of that, we also look at things like burnout for our staff. I'll come on to some of these and some of the areas that I've been talking about later on. Critical care outreach, or medical emergency teams as they're sometimes known, have been identified as being pivotal in supporting decisions to admit to critical care. I undertook some ethnographic research where we observed people in practice and various record reviews showing that critical care outreach are crucial in initiating the decisions with both patients, families and the medical teams. There's a need for negotiated transitions. These are difficult decisions to make and they have to be shared decisions with patients. And the role that palliative care can play in those was also emerged from some other research that we've been doing involving colleagues at the Royal Marsden. What we've seen in the pandemic is that outreach have had a really big role to play. So we've been conducting some service evaluations around this. And actually, because the families aren't present, and in the UK there is restricted visiting for families, this has been really difficult. And actually, the implications of this are not yet known long term for families and to ensuring family-centred care. So one of the angles of work that we'd like to focus on in the future is how critical care outreach might be better supported to take these decisions and to work with the medical teams to ensure timely and appropriate decisions for patients. We know in previous research that families struggle with communication with critical care staff, and they're often absent. Families are seen as linchpins, but they have many unmet needs, particularly when it comes to discharge. We're about to start some feasibility testing of a new app, which will be really important, particularly in light of the restricted visiting I mentioned. We're also looking at people who have long-term and chronic critical illness. We want to ensure the person-centeredness or patient and family-centeredness shines through in all of the approaches and all of the care that we provide. We know that post-intensive care syndrome is a particular problem with our patients who are discharged out of critical care. The families and patients experience problems in relation to this. For many patients, they will have problems that are psychological issues as a consequence of being in critical care, including post-traumatic stress disorder, anxiety, depression, memory problems, cognitive impairment. They may not get back to work. There may be problems with their family and the impact from their critical illness. They often have significant physical issues as a result of being in critical care, particularly if they've been in critical care for a long time. And I'll come on to how this has affected some of the COVID patients in particular. They can have problems such as loss of function, musculoskeletal problems, pain problems, swallowing, respiratory problems, and ICU acquired weakness and fatigue is a particular issue. The global burden in relation to post-intensive care syndrome is not to be underestimated. 1 in 4 people are readmitted to hospital within 90 days of being in intensive care. And actually the 5-year mortality is a third. Less than half are able to go back to work at the previous level that they were working at by a year, and 1 in 4 require ongoing care assistance. That may be informal through families, but it's still a very high number. The incidence of depression is as high as 43% and post-traumatic stress disorder at 35%. Having been in critical care, it's a really, really difficult time and can be very traumatic for a lot of people, as we see. And if you compare this with the general rates of anxiety and depression in the population, it's a significant uplift, as you can see. Cognitive impairment is also problematic, and with COVID, it's understood to be much higher. We know that for patients who are admitted to critical care, they are more likely to access healthcare services in the year following discharge. They report many more visits to their GPs and are often needing to be readmitted for some of these problems that I've outlined earlier. The consequences for individuals is significant. The average length of stay is much longer because of how sick these patients are. In our critical care unit, the average length of stay was 15.5 days, and the national length of stay was around 12 days, and this compares to around 4 days usually. So as you can see, these are much sicker patients with very long recovery trajectories. This is one of our patients, and you can see us at the back there, the critical care team. And he came back to visit us and came to the recovery clinic. And actually, the ongoing burdens should not be underestimated. It takes people weeks and sometimes months to get back to their usual lives. Some of the specific issues that these patients encounter that are very specific to COVID include an increased level of thromboses. So very small, tiny little clots that might form in the lungs that might even end up causing pulmonary hypertension. People being exposed to steroids, which we know can help support these patients when they're critically ill. There are cumulative effects in terms of gastrointestinal problems and bone density issues. There are cumulative effects of having high sugars, which is seen in these very critically ill patients. And we have had patients who have new onset type 1 diabetes as a result of COVID. ICUAW stands for ICU acquired weakness, and this is secondary to having deep sedation. We know these patients have long-term neurological and muscular problems as a result of this, but they need the deep sedation to be able to tolerate the ventilatory practices that are needed to keep them alive at the time. They also may have problems with neurological consequences as a result of being proned, which is where they're laid on their tummies to be able to recruit the lung capacity and enhance their respiratory function whilst they're critically ill. But this can lead to long-term problems with shoulders and necks in particular, with trapped nerves. And no matter what we try to do to preempt these and prevent these problems, they sometimes still occur. For some patients, they have low levels of oxygen, despite being on maximum oxygen and ventilatory therapies. And there can be memory problems and cognitive dysfunction as a result of low oxygen levels in the brain. There may be respiratory problems, including tracheal and glottic injuries in the throat and in the breathing tube. And then kidney problems, and for some patients, even stroke, subarachnoid hemorrhage, for instance. And importantly, the emotional and psychological consequences of COVID are not to be underestimated. Now, the role of research is really important in how we treat these critical care patients. A large study, which was not specific to critical care but included many critical care patients, was the ICU study, and a large consortium of people led by Dr. Kenny Bailey and Professor Callum Semple looked at the characteristics of patients who are admitted to hospital. And they've now developed an algorithm that can accurately predict mortality based on certain factors such as the age, respiratory rate, certain inflammatory markers and oxygen requirements. And it can give the percentage or proportion and likelihood of somebody surviving the critical care episode and the COVID episode. The recovery trial, which has had a high profile media presence, led by Professor Peter Horby in Oxford, showed that steroid use, dexamethasone, in patients who were critically ill improved survival by over a third, which is not to be underestimated. And there are many other ongoing studies such as REMAP-CAP and other elements of the recovery trial that are seeking to look at new treatments. We've been involved in all of these studies here, and we were also involved in the genomic study, which I'll come on to shortly. The CLAP study, Caring and Learning During the Pandemic, is the study that Dr. Kath Montgomery and I worked on, developing recommendations to support staff to be able to care for these critically ill patients in such challenging circumstances. The genomic study, also led by Dr. Kenny Bailey up in Scotland, a colleague from Edinburgh, has recently identified that there are certain areas of gene activity that will be important. We've taken, with patients' consent of course, and with family consent where patients aren't able to give consent at the time, DNA samples from patients to look at the gene expression and the gene activity in patients who are critically ill, to be able to understand why some patients become so ill and others don't when they're exposed to COVID. We know that there are certain genes implicated with up and down regulation of those genes, notable in certain areas. The long-term consequences of COVID are also coming to light. However, this is an emerging area. There are several studies across the UK that are underway, and we don't yet really fully understand this phenomenon. However, in my clinical practice, I'm starting to really see these phenomena, and the extreme fatigue and respiratory difficulties can persist for several months. Headaches, insomnia have also been described. And actually, these are not to be underestimated. These can have a significant impact on people's quality of life, and these are areas that we are starting to do research in. As I mentioned, psychological and emotional consequences can be really significant. And those acute episodes can lead to long-term problems. And I see several patients in practice with nightmares, with particular anxiety issues, depression, and this is borne out in my research and in the literature. To try and prevent these problems, both physical, emotional and psychological, there are recommendations in the UK for how we follow patients up after they've been in critical care or ICU. They should have clear rehabilitation goals focusing on their physical rehabilitation, and they should be supported out into the community after they've been in critical care, up to 2 to 3 months. They should receive information about rehabilitation pathways and going to the ward, information about medical problems and summaries of events for their GPs, receive information about what to expect, and have functional assessments in due course down the line. During COVID, the Intensive Care Society and the British Society of Rehabilitation Medicine came together, and we created this document to think about how we might assess early rehabilitation needs for those having treatment in intensive care with COVID-19. And we came up with a framework that you can find on the link below. This has been a really fruitful and important piece of work that actually will have widespread ramifications to be able to support patients out into the community and to engage with community services and to meet their rehabilitation needs. Our own model of critical care recovery looks at a holistic clinical assessment using a particular framework. We support patients to articulate subjective health concerns, give them advice, give them information, give them follow-up appointments, and make sure that existing appointments are followed up on, such as cardiology, respiratory. We might well also ensure that there's safety netting in place, both for the patients and for their carers, and to ensure linked up care with community and specialists. Across the integrated care system in Hertfordshire, we now have a really good network of acute and community care providers linking with primary care to ensure that we have a joined up system to make sure none of these COVID patients fall through the net. In our critical care recovery clinic, we might also offer some counselling. We look at their critical care diaries. Again, I've done research in this area, and we know that diaries actually can help patients process their stay in critical care. So if there's a record of events completed by the families or by the staff while they are unconscious or sedated, this is really important to help them make sense of their recovery. We might liaise with GPs. We might also think about goal setting, and research is also part of this. So there's a large body of qualitative research, much of which is my own, and we've come up with several areas that centre on survivorship to help us understand which patients in critical care need support and how we can co-design services to best meet people's needs. We know that patients struggle first when they're going to the ward and the care that they receive on the ward. And one of our PhD students, Sarah Vollum, has completed a study in this area, which would be really important to take things forward in the future for how we might better support those patients on the ward to ensure they receive optimal care. They may also have chronic and long-term conditions, and the fear of being readmitted to critical care can be really difficult and challenging for some patients to get over. They may have to manage the consequences of ongoing treatment, either as a result of their chronic illness or underlying conditions if they have comorbidities, but also as a consequence of their critical illness itself. And it can be difficult to resume normal life, and mortality and that Damoclean sword is often hanging over these patients, thinking, will it happen again? However, interestingly, what has also emerged from my research is that some of these patients encounter post-traumatic growth, and having been through something as profound as a critical illness can help them become what they see as better people. They have a renewed focus on life, and sometimes this can be very important to help them reframe what's important in their lives. Sadly, however, not all of our patients survive. As I said at the beginning, around 16 to 17% of patients will not survive critical care usually, and in the pandemic, if they have COVID, it's as high as 39 to 41%. So we have to think about end-of-life care. This has been really difficult during the pandemic. As you saw, many of our patients have not been able to have their families visiting, and that's been very difficult. We also know that there will be consequences for families down the line, and they're much more likely to have complicated or prolonged grief as they weren't present at the point of dying and death. Being involved in video calls has certainly helped that. However, there are likely to be consequences for those particular individuals who witnessed their loved ones dying but weren't able to be present, or perhaps were just informed of their loved ones dying over the telephone. We also know that there are consequences for staff, and certainly previous research has looked at burnout. The CLAP study that I mentioned earlier with my colleagues in Edinburgh, again, this has shown that some staff are really struggling to deal with providing end-of-life care for critically ill patients in the pandemic. It's really important to understand how we can identify those who are dying in critical care to ensure that they have optimal and timely end-of-life care. And think about the interventions that we give people when they're dying in critical care. We have a really large body of literature in the palliative care arena, but less so in critical care. And this is one of the areas which we're working on at the moment. We want to establish exactly what measures might help in end-of-life care in ICU. And these documents, particularly the Faculty of Intensive Care Medicine Care at the End of Life, and which I was fortunate enough to be a core author, will hopefully help practicing clinicians to be able to provide good end-of-life care. We need to think about the resource considerations. These are really unpalatable things that people have to think about. However, globally, there has been a limited resource, and certainly in the US, they were starting to think about rationing and who might get those ventilators. In the UK, we were fortunate that we never got to that position. But it's not been easy to ensure high quality care with such diminished staffing and such large patient numbers, particularly in the absence of families. And the role of education and support is really important at this time. Using digital solutions, as I mentioned, to help facilitate contact with families has been one suggestion. However, the impact of that, like I said, has not been explored. So, what's next beyond the pandemic for some of these people? Well, we need to focus on the recovery arc out into the community and understand the implications not only for us but also for services such as long-term care and social care. We need to think about the implications and the ramifications for family and society. And we need to think about how we can support our staff to be able to care for these patients. We're hopeful that we can find the best treatment for these patients, and if we can't, then how can we best support them? And this is the area of my research focus. So I'd like to thank you for listening, and if you do have any questions, please do get in touch. And if you'd like to follow me on Twitter, that's my Twitter account. Many thanks. Bye-bye.